This podcast is brought to you by the ATMS, the Australian Traditional Medicine Society. This is FX Medicine. I'm Andrew Whitfield Cook. Joining us on the line today is Karl Landers, who's one of the principal pharmacists and partners of Kingsway Compounding Laboratory in Brookvale, Sydney. Since 2001, he's helped build a world-leading team that specialises in individual medicine, which prides itself on listening and empathising with both the patient and the practitioner. It's one of the most respected compounding practices in Australia and New Zealand. Karl is a member of the Pharmaceutical Society of Australia, the Australian College of Pharmacy, and the Pharmaceutical Society of Ireland, from where he originates. He's also been on the PCCA, the Professional Compounding Chemists of Australia, Advisory Board from 2012 to 2015, and was a member of the Pharmaceutical Society of Great Britain from 1994 to 1998. He has a special interest in biomedical disorders and has been a guest speaker at the International PCCA Conference in America, 2009, has spoken at various support groups within the local community, such as the Northern Beaches ADHD Support Group, and has given educational talks at some of the natural therapy colleges in Australia. Welcome to FX Medicine, Karl. How are you going?
Yeah, very good. Thank you, Andrew.
Now, I guess first we have to go back to your pharmacy days. You did pharmacy in Ireland, did you?
No, I actually did it in England.
In England?
The northeast of England, Sunderland University.
And was that where compounding sort of sparked your interest? Or, I mean, you would have learnt compounding as part of pharmacy back then, correct?
Yeah, well, we did. We had probably half of our course was sort of around that type of pharmacy. But I was probably more into the manufacturing side at the time. So, when I did my internship, I did it with Glaxo. And that gave me a pretty good background into pharmaceutics and how to make drugs the right way, how to make formulations, etc. So it was actually more when I came to Australia was where I actually got the, shall we say, the bug for doing compounding. And it was through a journal. There was just this small little article in one of the journals that was mentioned something about compounding, and I thought, well, this is something interesting. So at the time, we were doing retail pharmacy with a little bit of compounding, but it wasn't called compounding then. It was called extemporaneous dispensing. Yeah. And what we were finding was we weren't quite getting, we weren't seeing major improvements in quite a few of our patients. That they started on a particular medication, for something minor, say, for example, like a bit of stomach upset or indigestion or something. And then, a year or two down the track, they're on several different medicines and interactions are occurring and they're not actually getting better. So we thought, well, maybe if we could fine tune what we were doing in the pharmacy, the pharmacy compounding side of things, we'd be able to sort of minimize those effects, maybe have a few more choices in what we can give. So that was the first sort of, how would I say, that was the first drive for us to say, okay, this is something we can put into our practice. Yeah. And as it turned out, then we had a close friend of ours, his name is Tony Mazzi, which is a very good compounding pharmacist we met. He was doing a lot of work with autistic children at the time. Right. And he was using nutritional therapies. And when we sort of collaborated, and that sort of was the icing on the cake for us, because that gave us sort of the best of all worlds, you might say. So we could deal with sort of your sort of allopathic medicine, and then you could deal with your natural medicine, and the two sort of meld together, and that's how we got into the nutritional compounding. Compounding
has been something the pharmacists have been doing for decades, eons. They used to make up Whitfield's ointment, even though there was the pre-made things from not Gold Cross, but, David Craig and these suppliers.
Yeah, that's right. It was called extemporaneous dispensing. That was very basic formulations been around for a long time. They had their place, but today compounding is a completely different beast altogether. So, you wouldn't be making up the compounds that we would do in a back of a retail store or anything like that. That would not be appropriate.
I still remember pharmacists making up coal tar creams and things like that in a specific strength as required by a GP for, let's say, a psoriasis or a dermatoses. Yeah. Very often they were creams. But in the olden days, when you see these old pharmacies and you see the carboys, the glass carboys and the glass jars with squill and gentian and things like that. So what really interests me is that pharmacists were herbalists.
Well, yeah, absolutely. I mean, if you want to go back a little bit further, let me put it this way. There's part of pharmacy is called pharmacognosy, and that's the study of the plants that are used in treatment healings, and how you can extract things from those plants to actually, make into a formulation for a person to use. So, yeah, it is a bit of an irony that the pharmacy, where it's more based on pharmaceuticals today, but its origins are quite firmly set in the actual herbal industry. And it just depends how far you want to go back. I mean, we've got some really old formulation books which are full of different type of herbal tinctures and things like that.
Wow.
Which were the norm. Yeah. And if you think of the RX on a prescription, that actually stands for recipe. So when the prescribers were actually doing it, they would create a recipe of what they were going to make for the patients. And yeah, every pharmacist was making up all sorts of wonderful things many years ago. But then, of course, with the advent of making it a lot easier, the manufacturers started bringing out set formulations, and that sort of art of what we call the art of compounding has been lost. But it's back now.
So what interests me, though, is that now, of course, there's that part that previous stuff is now untrue, because it's now called pseudoscience by a lot of people.
There's probably some sort of political agendas that go on there, which aren't in the best interest of science and patient health, unfortunately.
Yeah.
To me, the proof's in the pudding. At the end of the day, is the patient getting better, and there's many different formulations. There's many different parts of healthcare which all sort of combine together to help the patient. I think it's not just the pharmaceutical industry. It's not just natural therapies. It's not just chiropractors or physics. It's all of them together, coming together as one. Really is the ideal. But we'll just have to sort of watch this space and see how that pans out over the next number of years.
That's the definition of interdisciplinary, but it tends to be shanghaied in certain circles. But do you have an official definition of what compounding is?
If I could, off the top of my head, I mean, it is the process and art of formulating a particular compound for an individual patient. So it's specifically for one person. So you can't really do double-blind clinical trials on compounds because N equals 1. So it's basically personalized medicine.
I think the important thing that you mentioned there is individual. So it's individualized medicine, and therefore it's not a batch. And I think this is where some confusion comes in. So there's a difference in legalities, if nothing else, than with regards to batch manufacturing. Can you briefly go through what batch manufacturing is?
Yeah, look, there's quite a distinct difference. So when you manufacture something, you do it under what's called GMP practice, which is good manufacturing practice.
Yep.
Now you have to have a particular license from that, and if you're making anything got to do with medicines, you have to get a license from the TGA, the Therapeutic Goods Administration. So manufacturing will make one type of medication for many people. That's the biggest difference. So the process and regulation that has to go on for that, well, you got to make sure that you're 100% positive that what you're actually releasing to the public is exactly what it is, be it for whether it could cause harm, be it be the wrong dose, or be it doesn't work. So, you could be making one product and they could be making 1 million packets of it. So you don't want that affecting 1 million people if something went wrong. With compounding, you're dealing one patient. What are their needs, their specific needs? And you're going to have somebody making it from scratch, literally from every little active ingredient, putting it together and coming up with something to suit. So there can be a bit of trial and error at the beginning, but there's a lot of experience with it now, and around the world. And there's quite a significant number of studies which show the benefits of various dosage forms that can only be compounded.
Right.
So it's very hard to upscale a compounded product to a manufacturing as well. So there's that part as well. It's just, for example, if you're making some capsules or tablets in manufacturing, you use magnesium stearate, which is used as a lubricant. Mm-hmm. That's not just a lubricant for the tablet; it's actually for the machines, so that the powders can flow and they can make. Otherwise, they'd seize up. Whereas in compounding, we don't have to do that because we're doing it manually.
Gotcha.
So we don't need to use magnesium stearate. So things like that. Yeah, the manufacturing is GMP, whereas we look at compounding as CMP. You might say compounding practice or compounding manufacturing practice. But I can't use the word manufacturing because we definitely can't manufacture. So we can't make up a whole load and then sell it to some people, to people for them to on-sell or anything like that.
That's right.
That's impossible.
And that requires a batch, where you have a use-by date, you have a batch number, you have tracking of the ingredients, where it came from. I'm going to guess here, and forgive me if I'm wrong, but do you then have to be involved in testing of a batch?
Well, yeah, look, I suppose the way compounding has now progressed to is for example, we would definitely test our products. We would have to do sample testing. So we'll take random samples which we'll test to see that our processes are correct. We'll do samples to check that the technicians are actually following the standard operating procedures, making things right. All of those things that you would expect, like recording your batch numbers, everything, that's all done in compounding. Well, certainly done with us, where we can record it to the second, so we know exactly when something's being made. We have, the way it's being made. The laboratory is, they have temperature, pressure, humidity controlled environments where they're critical to ensuring a consistent compound. So the advancement in compounding has really gone in leaps and bounds from just a pestle and mortar. I mean, we would rarely use a pestle and mortar today because the advance in the machinery and the equipment is just so much better now that you can get a quality compound that is as good as if what you would get as a manufactured product.
Wow.
So around the world, I mean, it's quite compounding is quite renowned around the world, especially in Brazil, the United States, Europe. It's been going on for a long time before Australia sort of picked up the baton.
With regards to prescribed ingredients, off the top of my head, let's say it's a pregnenolone or progesterone, Troche. Being an individualised medicine, can a GP still write repeats for like a maximum number? Let's say 5 repeats seems to be the maximum. Or does the patient have to see their practitioner each time before a refill is made? What's the legalities of that?
Look, there isn't really much. There's not some sort of legal obligation with repeats or anything like that. Right. And the repeats have come from what we would normally do with PBS dispensed medicines, which are just your regular things. So there are limits as to what you can actually allow for repeats for particular reasons. So that there has to be a follow up, etc. Usually, what we find is with compounded products is that for the first few compounds that are made for the patients, the practitioner will have a follow-up appointment maybe 6 or 8 weeks later to see how they're actually responding.
Yep.
Now, we would also, follow up the patient and see how they're getting on. If there was nothing happening, we usually would contact the practitioner and let them know. So maybe there has to be a change in the dose or something like that. But the reason there are some people that get stabilized. So if you take those troches, for example, or particular creams, then what would happen is maybe after 6 months that the patient is stabilized.
Mm-hmm.
Practitioner might say, okay, well, everything's working fine now. You can continue on that dose, and here's a repeat. Usually they'd only do 1 or 2 repeats because they'd like to see the patient again, maybe 3 or 4 months later, just to make sure everything is right.
Yeah.
It's not a legal issue. It's not really a legal requirement or anything like that. It's really up to the practitioner when they want to see the patient again.
Yeah, so it's more of an assessment issue.
Yeah, it is, yeah. So prescribe an amount that would allow the person to have enough for at least 2 weeks after your next appointment. That's sort of the rule of thumb we work on, just in case there's delays or anything like that.
Yeah. And of course, I guess most people or many practitioners would be aware of the compounding of prescription items. But what confuses me a little bit is I've been aware because I've been exposed to it. There's two GPs locally that do compounding of certain nutrients. But compounding of nutrients is actually something that you do as well. So it doesn't have to be a prescribable item as per a doctor's prescription. Naturopaths can use a compounding pharmacy to compound specialized nutrients that they want to get in a certain dose, a certain form, or even a certain type of nutrient. Is that correct? Yeah,
absolutely. Yeah. The legal requirements is that if we make up a compound, we require a prescription. And now prescription has got many different meanings. It's basically an order. That's what it is. It's like just an order form. But in medical terms, we call it prescription. So a medical doctor is allowed to prescribe medicines on Schedule 4 and Schedule 8 in the poison schedule, as it's called. Now, they're your straightforward pharmaceutical products. Naturopaths probably wouldn't have much use for those, although they might work as in collaboration with other practitioners. When it comes to naturopaths prescribing, or for that matter, nutritionists or chiropractors or whatever, usually having a little bit of background knowledge of that type of prescribing is pretty good, and that comes sometimes with extra training and stuff.
Yeah.
But they can actually write down, pretty much any type of formulation that they want. The strengths, the form of the raw material, sometimes it can be raw materials that are products or raw materials that aren't available in Australia, but yet they are available and used quite successfully overseas. A compounding pharmacy can get in those raw materials and they can put together, the appropriate formulation for the patient. And it really comes down to what is the practitioner's, how high is the sky,
I guess the rule of thumb here is within their scope of practice. So, for instance, a naturopath can't prescribe pregnenolone, progesterone. That's out of their scope of practice.
Exactly. Yeah. And so I mean, the opportunities are just enormous for practitioners. It's when certain products haven't actually worked for some of the patients. So there's plenty of great practitioner ranges out there in Australia, which are quite fine and patients have got great success in. But then there's the in between. There's just those little few where it hasn't quite worked, or there's too much of a particular nutrient that they don't want to give. And that's where compounding can come in and say, well, let's formulate something specific now for that patient. And we work with the practitioner, get a little bit of background from the patient, and then come up with a formula and then see how the patient responds. So there's quite an enormous opportunity for naturopaths to fill in that gap now.
Yeah,
and they can be guaranteed and certain that it's going to be made in the right way, and it's going to be the correct dose, and it's going to be backed up by the compounding pharmacy. So that's probably the other thing is that people don't realize that in order for us to make the compound and actually release it, we also have to do a risk assessment to make sure that it's appropriate for the patient.
Aha, good.
So that if we've got any doubt that it's not appropriate, well, we just simply won't compound it.
Yeah,
and that's a very good backup support to have with practitioners as well. So that they understand that there are some things that may not be the best things, even though there might be some minor studies on them, or there might be studies done in mice, or there might be studies done in whatever. But to apply to a person in a clinical setting just might not be the most appropriate thing.
What does fill me with curiosity is, why aren't naturopaths and herbalists using this already, particularly naturopaths? Because a herbalist will be compounding every day of the working week. That's what herbal medicine is. It's compounding a particular preparation for a particular patient. And there indeed are extemporaneous nutrients made by supplement companies. But what I don't understand is why naturopaths don't use pharmacies that are well equipped, particularly from a quality perspective, a cleanliness perspective, with the equipment that you have, indeed the requirements that you've got to have to be able to use these compounds for their patients on an ongoing basis. So my next question is, what nutrients do you find are more common? What do you get use of?
Well, look, to be honest with you, there's nothing specific. It's pretty much everything. I mean, all your vitamins, all your minerals, amino acids, herbs. It's pretty much anything that's not an S4.
You're right.
So the choice is limitless, really. And it just comes down to how that formulation would be the most appropriate for that patient. So, for example, you could, a simple one would be, say, for example, zinc transdermal cream. Mm-hmm. Okay, in pharmacy terms, in compounding terms, a zinc transdermal is a way of getting zinc through the skin, through the dermis, into the bloodstream. So you're getting systemic absorption. Now, usually people that have got zinc deficiencies have got absorption issues to begin with. So compounding a zinc transdermal is a very easy way of getting zinc into the patient without, having to go through the gut. So it bypasses. You can use much lower doses. It's nice and easy. And, for people where they might have skin conditions as well, they don't get good absorption, things like that. These things really can penetrate even the toughest skins, shall I say.
Right.
But they're also very good for children. So children, infants, where they're not going to be swallowing capsules or tablets or anything like that, and some of the things just don't taste too good. Very easy way of getting a nutrient through the skin. And that's just one of many. I could go through zinc. You can go through all your Bs. A lot of the water-soluble ones, the vitamins, are very easy to get through the skin. And you can get multiples. So there's plenty of studies done showing that you can get 5-6 different nutrients or minerals through the skin at the same time. And what the practitioner would do would be to, from the test results that they have, decide, yes, we need some of this. They're not absorbing it. We've tried it orally. It hasn't worked. We'll try the cream. So after about 8 weeks, they would retest again. And then you get a gauge on how much they're absorbing over that period of time. Then there might be an adjustment in the dose, up or down. And sometimes that gives the window, the window to be able to introduce oral preparations again further down the track. So we try not to think of it as using a transdermal cream all the time, but use it as a way of bridging a gap, you might say.
Just thinking about creams, obviously you've got a base to carry the active in. Do you change the base at all with different skin types, different maybe conditions that you might be treating?
Absolutely, yeah. The choice of the base is very important. So luckily today that there are quite a few compounding companies that supply a whole raft of different bases. And they're all excellent. So they can get really large molecules through the skin. They can get very ionic molecules through the skin. Poorly soluble. It's quite complex, the formulations, the base formulation themselves. But the result is that the person gets the absorption of the active. We also make our own, for example. So we understand the pharmacokinetics and the pharmaceutics of doing that. So you can make up your own particular bases. We try and use our own if we can. Because we have certainly, some sensitive patients and some of the ingredients that might be in some of the bases that are sort of readily available just might not be appropriate for some people.
Yeah.
Especially autistic children.
Well, that's a good point to carry on with. Do you find that maybe autistic children respond with a feel? Let's say they might respond better to a cream which disappears into the skin rather than an ointment which tends to sit onto the skin and get absorbed slowly. Do you find that issue?
Absolutely. Yeah, they're very tactile, and the different places you can apply it. Mm. Some people will apply it around the neck and the back, so the kid gets a little bit of a massage at the same time.
Right.
It relaxes them. They feel they get a nice response from us.
Right.
So, I suppose, what can I say? Yeah, it definitely makes an enormous difference, for those children. In fact, a lot of the preparations we make are usually transdermal to begin with for those children.
Gotcha. And I was wondering about patient compliance, but I guess, as you say, if they're receiving a massage, then it requires the application by, somebody, usually their parent or their caregiver. So I would imagine then that the compliance is actually high, not low.
It is, absolutely. That's one of the biggest problems with anybody taking medicine is compliance.
Yeah.
And if you can get, that's the number one thing. Sometimes it doesn't matter how you try and get it in, but they have to be using it consistently. Usually we find that taking anything more than twice a day it becomes pretty much falling off a cliff in terms of compliance.
Yeah.
It just gets too hard.
Yeah.
So if you can, even twice a day is the ideal, because even if you do it once a day, people can forget a day.
Yeah.
Whereas if you're doing it twice a day, the worst that they'll do is usually forget one dose.
Right.
Which means they can take their next dose straight away and move on and continue with it. So it sort of has a little bit of a safety net as well.
Good advice. And what about practical things like staining? It actually flows on from what you said. I'll always remember Mum, when we had a cold, she'd rub on the Vicks and it just felt gunky. But there was something nice about it, but you really had to wear a crappy T-shirt to bed or else it was everywhere. So what about things like that? Let's say, for instance, I work with calendula cream quite a bit with supporting my cancer patients. And that, I tell you, it's a bugger to stain. Do you have an issue with that, or do you tend to just, it tends to be whatever the characteristics of the ingredient is?
Yeah, it can be. One of the things with staining, it might have to do with the formulation. So if you're using a transdermal, there shouldn't be any issue with staining,
right? Because
you're going to get it all fully absorbed. Now, having said that, there are certain ingredients that may last a little bit longer in the skin, but it's not a lot. If you take pyridoxine 5-phosphate, for example, it looks yellow on the skin when it's applied.
Mm.
But depending on who it's been applied to and the condition of the skin, for some people within a minute it disappears, and for other people it could be 5 or 10 minutes before it disappears.
Yeah,
and that's probably more reflection on the health of their skin more than anything else.
Yeah.
But the staining, no. I mean, iron doesn't stain. We've got formulations now where people can get on in a transdermal as well, and it doesn't stain.
Wow.
Yeah.
Oh, that's really useful.
Yeah. So there are the advances, shall I say, in formulations is just it's just grown exponentially over the last 10 years.
Yeah.
And there's so many different ways. Even some items where people would like to take them and they smell, the particular ingredients. Well, now there's ways of actually masking those smells and stuff, so people find it more tolerable.
Yeah, I'm thinking, like pregnant women with B vitamins. Multivitamins and things like that, they gag very often and they become super sensitive to otherwise innocuous smells. Karl, what about things like safety? So, running through my mind is the old, topical application of an NSAID if they were also taking a beta blocker and an ACE inhibitor, and you might have a triple whammy. Now, I would imagine that that's probably a dose-related thing, probably more likely with an oral formulation, but do you have any issues that you've got to consider with regards to safety, maybe their kidney function or anything?
Yeah, look, the good thing, I suppose, is that when you do a compound and dosing, is you start with the lowest dose that works to begin with.
Right.
So there's always something in the background that you have to be aware of with anything that you put into your body. So anything you put into your body, first of all, be it natural or be it a pharmaceutical or whatever, there's always the potential for an adverse effect, and it can be caused by different things. So you can have an adverse effect by the drug itself, so that the metabolites that are coming from us actually have an adverse effect on the patient.
Yep.
But then you can also have nutrients and stuff where you might be giving too much of a particular type of nutrient, which is causing an imbalance in the biochemistry, and that's causing a reaction in the patient that is unpleasant. And that becomes a dosing issue. So you have to keep an eye on how the patient responds. So the feedback from your patient is extremely important, which we encourage as soon as anybody starts any compound, is that if there's anything unusual, if you feel anything unusual, doesn't matter what you whether you think it's small or big or whatever, let us know. And we can actually then see whether that's related to something else.
Yeah, well, I was thinking about this, that it would actually encourage the collaboration between you and the practitioner with the patient's well-being in the middle. So it really does become this two-way, talk about management.
It's what we call a triad, okay?
Right.
The practitioner, the compounding, and the patient. And it's the three collaborating together, which is very important. The response from the patient, how they feel, what's changed. Some of the things we do is for some people that try, they will write out, some of their symptoms or things that they feel need to be addressed, and we tell them to put it into an envelope and leave it, and don't look at it. And now, when you go through some of the treatment, we'll have a look. In 6 months' time, write down again now how you're feeling, and then they do a nice comparison. And 99 times out of 100, they're actually doing a hell of a lot better. And there's a few things on that list that have disappeared.
Yeah. Now, you said something very interesting to me earlier on, in that it's not just nutrients and your pharmaceutical preparations, but herbs as well. Do you tend to do liquid herbs, or do you have dry formulations as well?
We have dry, yeah. The reason we prefer to do dry is has to do with contamination. So when anything goes into a liquid, there's a potential for contamination or growth of microbial growth, etc., and also stability issues. Yep. So while giving something in a small dose, some herbs and stuff, and see how they respond for a week or two, that's all great. But from a compounding perspective, we have to be able to justify any expiry dates, or best before dates that we actually put on our compounds. And that can be in the form of doing our own testing and seeing what the results are, a few long-term studies, or looking at literature research and seeing what would be the stability of something. So, for example, if you made a liquid preparation, probably you can't give much more than 14 days on that unless you start having a study on it. You may be able to go a month on some things, but usually that's about it. Especially if you don't put anything like preservatives or anything like that, which is what most people don't want to have in their preparations. So we've got to be careful from that aspect of, we could be giving them something else, an infection or something like that.
Yeah, and people will drink straight from the bottle. You know that.
Absolutely,
they will.
So the dry preparations are much better. They're easier to work with. They can be formulated to a powder. So a powder blend. They can take a scoop of it or something and mix that with something else if they want. Something that they might, have a drink that they particularly, like the flavor of. You mix in with that. And other things we do is make masking syrups, which are really good when for some people where we'd make the capsules and they don't want to swallow the capsules, so they'll open the capsules and they'll mix it into a little bit of this mixture, and the combined effect is that they end up getting a much more palatable dose of their medicine. So there's easy ways around that, in terms of all that taste issues and whatnot.
Yeah. What about particular routes of administration? Now, we've mentioned creams, but let's just say, for instance, somebody wanted a calendula pessary for treating vaginal thrush. Would that be something applicable? You could do that from a naturopathic prescription?
Yeah, absolutely.
Yeah.
The issue with the issues that we would be looking at to make that would be its stability next to heat.
Right.
So part of the process of making a suppository is that you have to use some heat, but it's not much. You only go up around 58 degrees.
Yeah.
From my memory with calendula, I don't think there's any issues with that. That's not a problem. There's a lot of the herbs and a lot of the nutrients and things are very heat stable, so there usually isn't any issue. Yeah, and you can put in whatever. You can put in the calendula. You can put in anything else that you might think of. I know some people have even managed to get some probiotics into some of the pessaries.
Yeah.
As an example.
Just a couple of last questions. I guess the first one is obvious turnaround, and the last one is where can practitioners, natural health practitioners, get further information, or maybe contact you to discuss the potential of them using a compounding pharmacist for their nutritional requirements in certain patients?
Look, the way a practitioner should start is basically contacting the compounding pharmacy. So for us, we would actually sit down with them. Sometimes we sit down with them and we talk with them about what their needs are. Certain patients that they might see a lot of with certain conditions. So there's specific type of formulations they'd like to be working with. We work with them. So it's a learning curve that you have to start somewhere. But as time goes on, we found some naturopaths to become very versatile in how they use compounds, and they start to understand a lot more of the formulations and how they are. So the number one thing, yes, is contact us, is get in touch. Information wise, there's plenty of websites out there. We've got a practitioner portal in ours where people can sign up and then when you look at the particular compound or look at the nutrients or whatever that you just put in the search term, you can find a whole number of compounds related to that. And then with that there's information on how to prescribe. There's information like white papers and research articles and things like that, which we're growing organically as we speak.
Yeah.
There are ways. There's also conferences. There's conferences that go on about compounding, explaining how to use certain nutrients, minerals in compounding, and why you can you learn things about why this form would be better than that form. Why a sulfate isn't as good as a glycinate, but it's very good. It's very good in a liquid. There's all the different forms. There's so many different forms that you can get now of different nutrients and minerals that there's a few core ones, and then there's a few where you got to try something else. You got to try different forms. So it's not the formulation. It's just that active isn't the right for that patient.
Yeah,
and as I said, the knowledge will grow. The knowledge will grow, and look, it's only a phone call away.
Yeah,
as we say, just pick up the phone. You'll get through to a compounding pharmacist, and you'll get the information hopefully that you need. And it's collaborative. It's great. You work with we like it because we get a lot more contact, social contact as well with the practitioners. And at the end of the day, the patient is the one that we're trying to get better.
Well, I've got to say, I've learnt so much just speaking with you. I'll definitely be using more of compounding. This is awesome. I like things that I never even thought of.
Yeah, it's definitely from the old days of compounding where making things up at the back. Today, the advancements and what happens, as we've got, like, for example, ISO 9001 standards, which is internationally recognized. It's that level that it's gone up to.
Yeah.
This is what people have to understand. It's very highly sophisticated and very much stressed on quality and consistency that you just can't get from what you used to have years ago. So all of that sort of extemporaneous stuff will probably phase out, and people can now get really top quality personalized medicine. It's just brilliant. That's why we love it. Yeah.
Fantastic information. Thank you so much for joining us on FX Medicine today, Karl. Brilliant.
Pleasure, Andrew. Thank you very much.
This is FX Medicine. I'm Andrew Whitfield Cook. This podcast is brought to you by the ATMS, the Australian Traditional Medicine Society.